I'm Adair Call, and we're going to talk about hand and wrist pathology. I have no relevant disclosures. I would like to say that this presentation is not meant to be a comprehensive review of all hand and wrist pathology. This is meant to cover the core competencies as outlined in the AMSSM recommended sports ultrasound curriculum for sports medicine fellowships. Our learning objectives today will be to discuss de Quervain's tenosynovitis as well as carpal tunnel syndrome. The first dorsal compartment is comprised of the abductor pollicis longus and extensor pollicis brevis tendons. They travel in an osteofibrous tunnel bordered by the radius and covered by the extensor retinaculum. Typically, they share a single synovial sheath, but at times there may be two separate sheaths, which becomes important and will warrant further discussion later in our talk. They form the volar border of the anatomic snuff box. Lying in the floor of the anatomic snuff box is the radial artery, which sits deep to the first compartment tendons. The superficial radial nerve is also of importance as it crosses over the first compartment and is somewhat variable in its location at which it crosses, as well as its branching. And this should be identified in any normal scanning of the first dorsal compartment. We always want to orient anywhere on the dorsal wrist from Lister's tubercle. And as you can see in this extended field of view image, Lister's tubercle is readily seen as the hyperechoic ridge over the dorsal wrist. It's also readily palpable on your physical exam. This will separate the third dorsal compartment tendons from the second dorsal compartment tendons. From there, we can move further over towards the radial or volar aspect to identify the first dorsal compartment tendons. Typically, there is no appreciable sheath fluid, and you can evaluate the retinaculum at this area as well. So the retinaculum typically will be a very thin structure overlying. As that becomes thickened, that is a sign of pathology in the region. Often you will be able to identify both the APL and the EPB tendons, as we can see in the image below here. On these images, we can appreciate the superficial radial nerve as it courses over the first dorsal compartment. Oftentimes doing a dynamic scan will allow us to identify the nerve easier than static imaging, as we can see it's moving in its course. You can also feel this under your transducer typically, as it will snap over top of the tendons as we see here. Doppler can be utilized to identify the radial artery, although it's typically readily appreciated by its pulsatility and hypoechoic nature sitting deep to the tendons. There are a few anatomic variants that warrant further discussion. There's a vertical septum that can be seen separating the two tendons and effectively subcompartmentalizing the first dorsal compartment. And oftentimes this will be represented by a hypoechoic vertical band and an associated osseous ridge, as we see in this image here. So this is important because this has been associated with pathology, as well as can have implications for procedures about this area. Another anatomic variation are separate tendon slips of the APL. Typically these involve the APL, although less commonly you can see them with the EPB as well. This should not be mistaken as a longitudinal or split tear of the tendons. De Quervain's tenosynovitis is an overuse disorder with localized thickening of the retinaculum at the radial styloid, which leads to impingement and inflammation of the tendons and tenosynovium. As mentioned previously, the vertical septum is a risk factor for this and should be looked for and identified. You will often note thickening of the extensor retinaculum, as we can see in the image below here, as well as swelling and hypoechogenicity of the tendons themselves and fluid within the sheath. You may not see fluid surrounding the tendons at the level of the retinaculum over the styloid, just due to the increased pressure at that location, and the fluid may be pushed distally or proximally from that location. So always make sure to do a full, complete evaluation of the region. Doppler is also helpful to look for active tenosynovitis, as we see in our two images here, with flow around the retinaculum and within the tendon sheaths and even somewhat intertendinous. Here's a long axis image of the tendons, and we can appreciate the short axis view of the extensor retinaculum and its hypoechogenicity and thickening. And this is just another example of more hyperemia, both extending around the tenosynovium as well as through that vertical septum in this patient. Your differential diagnosis for pain over the first dorsal compartment includes first CMC joint arthritis, as well as intersection syndrome and Wartenberg disease. Intersection syndrome typically refers to the crossing of the first and second dorsal compartments, which is proximal to the pain typically associated with de Quervain's. There is also another intersection syndrome at the crossing of the third and second dorsal compartments that occurs more distally into the hand. In this image here, we can see where the first and second compartments are crossing over each other, as well as some slight hyperechoic tissue forming right at this interface between. This area was very tender to palpation for the patient, and we can also see hyperemia through that region as well. So these are typical findings of intersection syndrome. You may not see any of these findings in even classic clinical cases, and so oftentimes this will be a clinical diagnosis, and you can utilize ultrasound to perform injections safely into the region if need be. Wartenberg disease refers to a neuropathy of the superficial radial nerve at the wrist. This can be injured from trauma as well as iatrogenically from misplaced IV lines or injections into the area. Moving on to the carpal tunnel. The proximal carpal tunnel is bordered by the scaphoid on the radial side and pisiform on the ulnar side, with the flexor retinaculum extending over the top. The retinaculum typically is relatively thin at 1 to 1.5 millimeters and has a convex appearance as it extends over top of the carpal tunnel. The carpal tunnel contents include 4 tendons of the FDS and FDP respectively, as well as the flexor pollicis longus tendon, and then the median nerve. The flexor carpi radialis sits outside of the tendon, overlying the scaphoid. The flexor carpi radialis can resemble the median nerve in appearance, and its location outside of the tunnel is important in making this differentiation. Also, can you perform a dynamic examination, and as you move proximally, we'll notice that the median nerve will drop down and below as we move into the forearm. And as we move back distally, the nerve is going to move superficial and ulnar to the FPL. At this point, it will take on somewhat of an elliptical shape as it moves into the carpal tunnel. It should also move with dynamic imaging of finger flexion, and lack of this movement has been associated with carpal tunnel syndrome. As we move distally down into the wrist, we'll find the carpal tunnel outlet, which will be formed by the borders of the tubercle of the trapezium on the radial side and the hook of the hamate on the ulnar side. Because the hamate is somewhat more centrally located, the outlet is a bit smaller than the inlet. The distal retinaculum is also slightly thicker at this location, and because of this, the median nerve will have somewhat more of a flattened appearance normally, so that should not be misinterpreted as pathologic. There are a few important anatomic variants to note within the carpal tunnel. First, you should identify any anomalous muscles or tendons that lie within the tunnel, as these can be associated with carpal tunnel syndrome. A few of these to consider are reversed palmaris longus, an anomalous FDS muscle, or an encroaching index lumbrical. These latter two can be seen dynamically with flexion and extension as they come into the tunnel and can cause intermittent compression. Bifid median nerves are not an uncommon finding, as we can see in this image here. There's various forms of these, from a true two separate nerve bifid appearance to an image closer to this. Often these will be accompanied by a persistent median artery as well, as we can see on the Doppler evaluation here. And these are important things to mention in your report and should be taken into consideration for any interventional treatments. In terms of a carpal tunnel diagnosis, the AANEM practice guidelines did state that ultrasound measurements of the median nerve cross-sectional area is an accurate measure and may be offered as a diagnostic test for carpal tunnel syndrome. They also acknowledge that ultrasound adds value to electrodiagnostic studies in terms of identifying potential anatomic reasons for compression in the area, such as those that we've mentioned already. When making measurements of cross-sectional area, these typically should be performed at the proximal inlet. There are various numbers reported in the literature, but it's safe to use a greater than 13 millimeter cutoff as abnormal with some borderline values between 10 and 13. You can also use a ratio where you measure the cross-sectional area at the inlet and then proximally over the pronator quadratus with a ratio greater than 1.4 being abnormal. You can also just look more globally at changes within the nerve, such as within the fascicles. We would call fascicular loss or a relative hypoechogenicity of the nerve, lack of excursion with finger flexion, as well as focal swelling of the nerve. One disadvantage of ultrasound compared to electrodiagnostic studies is that you are not able to reliably determine the severity of the neuropathy. Here are a few examples of carpal tunnel syndrome. Here we see a short axis view and a cross-sectional measurement that's grossly abnormal at 0.24. So many times these will be not within that borderline zone, but actually quite large, as we can see here. And this is a long axis view of the same, and this is one of the other things we look for is this focal swelling, so you can see the abrupt change in the nerve at the site of compression. And that concludes our lecture on wrist pathology. Thank you.